Yes, sir.
Request control, please.
Yes, done.
65-year-old male patient with acute, 1 second. 1 second.
Okay, I have been provided by axial CT abdomen.
1 second. 1 second.
Yes.
With severe abdominal epigastric pain for 12 hours. Go on.
I have been provided by CT abdomen axial images for a 65 years old male presented with abdominal pain for 12 hours. I would like to have a general look before starting my comments.
Okay.
Okay, scrolling is not working. Okay, would you scroll for me, please?
Use the arrow. You were scrolling well. Use arrow.
This is no.
1 second. 1 second. You can use the arrow. Use.
No, it's
What?
not moving.
Okay. See.
Okay, this is me. Okay, so I can see that there is a large abnormality involving the entire pancreas, appearing as a large peripancreatic collection. The
Okay.
pancreas is very bulky
Yes.
and contains a heterogeneous collection. Again, I cannot scroll. Okay.
Yes.
So the entire pancreas is involved by this process, which is likely an inflammatory or infectious. I would like to
Yes.
check for the complications of this, including the vascular involvement, searching for
Yes.
areas of aneurysms and leak, searching for involvement of the adjacent bowel loops, and other associations. Dr. Wallahi, I'm facing great issue with the scrolling.
We have today an internet problem.
Okay. Okay, thank you. So, my differential diagnosis till this point is interstitial pancreatitis.
Are
I
you
would like
sure?
to look for the
Look
cause.
again. Look
Okay.
again.
Okay. The fluid collection around the pancreas is inflammatory process. It is pancreatitis.
Yes.
Necrotizing
What type?
pancreatitis.
Why?
Pancreatitis. There are multiple areas of non-enhancing pancreatic tissues. Okay, so I would like to look for the cause, including gallstones at the top. I saw one gallstone at the region of the gallbladder. I would like to look for dilated pancreatic duct and biliary tree.
Yes.
So yes, there is gallstone,
Yes.
CBD stone, I think.
No, this is gallstone. Gallstone.
Okay.
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 Look
No
down there.
no intrahepatic biliary duct dilatation.
Look here.
The pancreatic duct.
Look
Yes,
here.
this is CBD stone. Yes.
Yes. So, what's your opinion?
Okay. So obstructive biliary stone causing
Okay.
necrotizing pancreatitis. This is an emergency. I would like to urgently convey the findings for the referring physician for urgent ERCP removal of the stone. The
Excellent.
patient would like to correlate with the pancreatic enzymes. The patient is for urgent management and follow-up. Maybe IR
Excellent.
drainage of this collection.
لا
Removal of the
drainage.
gallstone in the future of the gallbladder.
No, Dr. Nagam, you were in the correct pathway. How can we drain all of this? And the patient is very
It should
elderly.
be it should be okay, conservative right now. Then for
See, actually, we don't know because pancreatitis management depending on the score. They have a specific score. I didn't mention the name. Second, it in my opinion, it has many. See here, I think here it may be necrotic area here.
Yes.
Maybe. So it needs clinical evaluation because if this is necrotic pancreatitis, the management take another pathway completely. Okay,
Okay.
but you pick up the stones, and it was not an easy case. This is the most important. So this is acute pancreatitis due to a common bile duct stone. What happened here? That this stone. One second. This stone make a reflux of the biliary content into the pancreas. Okay. Hello. Hello. Hello.
Pancreatic secretions?
Yeah.
Yes,
What
sir. I
happened?
can
What is the
hear you.
pathology? Yeah. What is the pathology? Obstruction of the CVD cause a reflux of the biliary secretions into the pancreas. So it activates the pancreatic enzymes. So the pancreas digests itself. Very critical. Okay. Thank you, doctor, so much. Next candidate. Thanks, Dr. Nagam. Dr. Nagam did a lot of effort every day, and she tolerate a large headache. I follow her and for sometimes at the group, and I pay for her only. Next
With
candidate.
pleasure.
Welcome, Dr. Next candidate.
Yes, sir. Assalamu alaikum, sir. I'm candidate.
Alaikum salam. Request control,
Yes.
please.
Yes. Yes.
70-year-old female male patient presented with abdominal pain and the mass feeling in physical examination. Go on, doctor.
Sir, I'm provided with a multi-sequential MRI images. This one is scintillated image. Okay, sir. I'm just scrolling from top to bottom.
Yes.
I can appreciate there is a large heterogeneous
Yes.
solid cystic mass is identified involving the segment 6 of liver, which is pretty well defined with some central cystic areas and shows a well-defined margin hypovascular capsule. It is causing compression over the kidney.
1 second.
And I
Hello?
yes, sir. Yes.
Yeah, okay. Please, my
Okay.
colleague, mute yourself, except the candidate online on the hot seat. Number one.
Yes, sir. So, sir, I'm just observing a large heterogeneous solid mass with an encapsulated mass with a solid as well as cystic component. Similar signal intensity lesion also identified involving the left kidney as well. Yes, sir. It is seen arising from the upper pole of the left kidney and causing compressive effect. I want to, sir, check other images as well. For example, sir, post-contrast images to
You
look for
didn't
this lesion.
see, doctor, before going
Yes.
to other images, you didn't give me
Yes.
more details. What happened here?
Okay, sir. Sir,
What
this
happened?
lesion is seen to be arising from the liver, and
Okay.
I think
What else?
it's well
Look
defined.
inside the lesion. Look inside
Yes,
the
sir.
lesion. Look inside.
Sir, okay, sir. So inside the lesion, there are multiple cysts as well
Okay.
as some enhancing septa. Sorry, not enhancing, but there are septa and multiloculated cystic lesions.
Okay.
Sir.
What is the name of this appearance?
Sir, this, sir, I think it's, I'm concerning this about as a hydrated cyst. Maybe it's
Okay.
showing
Okay. What is the name
multiple
of this
cysts.
appearance? Yeah.
Sir,
What is the name?
Sir, something glaring is there, water lily sign and some, sir, different
This is
signs
not
give.
water lily. See. This is
Not
not
water
water lily.
lilies.
Yeah.
So
This
it's
is
a bunch
something
of
else.
grape. Yes, sir. Bunch of grape or honey hopping sort.
Yes, but there are another common name.
Oh,
Anyway, daughter cyst. Daughter
Daughter
cyst.
cyst. Yes.
Okay,
Yes,
yeah,
sir.
go on. What else?
Sir, this similar signal intensity lesion also seen involving the left kidney or as well. So these are
Okay.
causing compressive effect, but I don't find any outline rupture like liver parenchyma is to be fine. I don't find like it's seen rupturing within the liver. And also, so no such lymphadenopathy, but it's causing mild compression over the gallbladder, but no intrahepatic duct dilatation in these images.
Excellent. If you find the intrahepatic biliary dilatation, what does this indicate?
Sir, it indicates it may rupture within the biliary channel or it may causing compressive effect. Both possibility would be there, but rupture chances are.
Yes. Okay. So, what's your diagnosis?
Sir,
Final diagnosis?
sir, I would give differential for the hydrated cyst. I would inform my finding to the referring physician in about the echinococcus titer of the patient, as well any previous imaging, because this maybe they have a long-standing history, so
Okay.
calcification and other things as well. So if any previous history available, and this also multiple, I also want to check the lungs as well as the whole entire body because they are multiple, and they require also interventional review as well because we need to aspirate, but this seems to be multi-loculated. It's less likely to be successful for intervention radiologist.
Doctor,
It
what's
must be
your
this separate.
management? No. Stop. What's your
Yes.
definite management?
So
This is
definite
very
is
critical.
pair. Yes, sir, it's a
Yeah.
pair procedure, but this is a multi-septated. In normally pair, if you have a less septa, we remove the septa through intervention and then aspirate, and then
No.
pair procedure.
No. This is hydatid cyst.
Yes, sir.
Only the management, only one
Resection.
procedure. Resection. Okay. Is aspiration possible for hydatid cyst or not?
Yes. So in this case, it's not possible because it's
Why?
multi-septated. If so, because
Okay,
multiple
why?
septation, if we remove one septa, the other locules will be there. So it is not
No,
unsuccessful.
doctor. If you aspirate hydatid
Yes.
cyst, it may cause
Yes.
fatal anaphylactic shock.
Chemical.
Yeah.
Yes.
No any word after that. يعني according to my knowledge, I didn't know at all about any type of aspiration. Generally,
Okay. Sir,
what
but
we used it. Yes.
pair procedure usually done in which there's aspirate the content and then instill the this anti-protozoonic. Mostly we do need
In my
this pair
opinion,
procedure.
common
Yes.
is common. And I just
Okay.
inform you about my mistake in one exam. I told the examiner something true. It was a true, and I'm sure it is true, but it is uncommon. Uncommon for
Yes.
him, not familiar. He didn't
Yes.
pass me in this case. Okay, doctor?
Yes.
Thank you so much,
Okay.
my colleague. It was a case of liver and left renal hydatid cyst. Why? Look here. It looks like ovary, polycystic ovary. Very easy. Big cyst and daughter cyst. Okay? Your management, next, number one, I wanted to rule out any other lesions, especially in the lung and the pleura. One of the most important differential diagnosis when you find a big cyst in the lung, hydatid cyst. Very important. Number two, management will be surgical removal. For according to my knowledge, I didn't hear about anything other than surgical. The doctor did something very well when she told there are no biliary dilatation here. Okay, why? Biliary dilatation is an indication or a sign of rupture. See, the cyst is not enhanced. Rupture. When you find a biliary dilatation here, this means the hydatid cyst ruptured and go inside the biliary tract. Thank you, doctor, so much. Next candidate.
Hello, Dr. Rami.
Hello.
Yes.
Access control, doctor.
Yes. Okay. Requested. Thank you.
This is 2-year-old, 2-year-old male patient complaining of severe abdominal pain.
Okay, this is axial. This is axial cuts, axial CT, abdomen pelvis with contrast for a 2-year-old male patient presented with abdominal pain. I will scroll through the whole images, then I will give my comment.
Mm.
Okay, so the most striking abnormality is that there is a marked ascites seen within the abdomen, pushing the bowel loops centrally, with a large locule of air, which I would like to check if it's intra-luminal or not. I think this is extraluminal. And I can see that the liver is heterogeneous, enlarged, heterogeneous. And there's bilateral pleural effusion as well. So the liver appear enlarged and heterogeneous.
Okay, what should we do?
What else?
I can't see definite lesion in the liver. It appear.
Concentrate on the liver.
Okay.
Just mention.
What is the name of this appearance?
This is the
Yes, correct. Yes.
nutmeg liver.
Yes.
Yeah.
Doctor, I told you before many times, what is in your mind is a correct answer. Really,
Okay.
really. Yeah, correct.
So,
Again, what is this?
nutmeg liver.
Okay, and the answer in your mind is repeat the correct one. Okay.
Yeah. So this is
Yes, go on.
nutmeg liver is for congestive hepatic disease. So this is Hepatobiliary.
Excellent. Where is the hepatic
I
veins?
can't see the hepatic veins, and yeah, I can't see the hepatic veins here. This
Excellent.
is port. So the hepatic veins cannot be seen. So yeah, this is Hepatobiliary syndrome with marked ascites. I will send the patient to the
One
pediatric
second. Give me the mouse.
Yeah.
Which phase this one?
This is the arterial phase.
Okay. Look, concentrate in the contrast, please. Concentrate here. Look here. What happened? Is there any change? Again. Look here.
Yes.
Here,
Okay.
there are peripheral hypoenhancement.
Yeah. Okay.
Okay. And mainly central here. See here, what happened? There are peripheral enhancement and the opposite.
Yeah,
Central
flip-flop.
less. Yeah, excellent. Flip-flop. This is, by the way, my colleagues, this is the flip-flop enhancement. What is the flip-flop? What you see in arterial, you almost will see the opposite here. The peripheral non-enhancement or hyper-enhancement, see here in the venous, okay, will be enhanced. And the center is the opposite. Okay, what happened for the caudate lobe here, doctor?
Hypertrophy.
And enhanced or not in both arterial and yes, because so it means the caudate lobe is spared. Why the caudate lobe is spared here?
In the back there is a spearment of the caudate lobe.
Why?
I think.
Why?
Because the caudate has different another venous
drainage. Excellent.
Drainage, yeah.
It has another venous drainage. Excellent, doctor. What's your management? What's your next step?
Actually, in Hepatobiliary, we need to give. They need to do portosystemic shuntings.
Okay.
And hepatic venoplasty.
Okay.
So I will
anticoagulant.
Maybe. Yeah, and give anticoagulant. Yes. They need a long-term anticoagulant. So I will refer the patient to the pediatric surgical surgeon urgently.
No surgeon, GIT.
Okay, pediatric
You are
GIT.
seeing. Okay. See, they did here angio.
Angiography, yeah.
Angio. Okay. They did angio. Thank you, doctor, so much. It was about
Thank you.
Perry syndrome with the free flop and nutmeg appearance or dirty appearance. The nutmeg, you can call it dirty liver appearance. Next candidate. Thank you, doctor.
Okay, thank you.
Yes, sir.
Request control, please. Dr. Nagam,
Alright.
how many candidates remaining, please?
I'm candidate 12. I think we have 15. 15
Okay.
and candidate 5 is joining at the end.
Okay.
So 3 remaining.
Okay. Yeah.
Okay.
Did you request control?
Yes.
70-year-old male patient presented with acute severe abdominal pain. Go on.
Okay. I'm presented with CT scan axial sections of abdomen in the portovenous phase. First, I'd like to go through the images and I will start describing my findings. I can see some surgical clips in the region of prostate, which could indicate that patient has brachytherapy of prostate or
Excellent. Excellent. But this is a
due to
side
the
finding.
prostatic carcinoma. Sorry?
See, you are right, but the complaint in the abdomen.
Yeah, okay, yeah, I'm looking now at the abdomen. There are some atherosclerotic changes in the aorta, and as I go up, I can see that there is significant, well-defined collection formations with
Excellent.
internal air locules seen in the region of gallbladder fossa. I
Okay.
am looking at the gallbladder. I cannot see the gallbladder separately.
Okay.
And these collections are seen in the region of gallbladder fossa and are also adherent to the adjacent wall of the stomach and also of the hepatic flexure. There is also
Okay.
marked fat straining in this region of the hepatic flexure, and uh, no surgical clips are seen. I would like to know if there's any history of surgery of
No.
cholecystectomy.
No surgery of cholecystectomy.
All right. Um, then these are likely collections in the gallbladder fossa. I'm looking if there is any evidence of diverticulitis in the hepatic flexure or colon, but there are no such diverticulae seen. So it's likely a case of collections and infective process in the region of the gallbladder with ill-defined walls. I cannot see the normal mural enhancement of the gallbladder wall and air is seen. So
No,
it's
no, no,
likely
no, no,
infective
no,
process,
no.
likely
One sec.
emphysematous.
Yes, yes. You didn't
Likely
see the
emphysematous
normal gallbladder. Yeah.
yes,
Mm.
I cannot see the normal gallbladder and no normal enhancement. So it's
Yes.
likely emphysematous gallbladder with the adjacent collection formations in the adjacent hepatic parenchyma.
Okay. What
I will
history do you want to?
immediately, sorry,
What history do you want to ask about this patient?
I want to know that the if patient is diabetic or any yes, if there's any history of diabetes or
Yes, yes, correct. What is your management?
I will immediately pick up the phone and inform the findings to the referring clinician as this is an emergency and it needs to be urgently managed. Otherwise, patient
Okay,
can develop necrosis
okay. In your opinion,
and
what is
sepsis.
the means of management here? What is the surgeon will do?
It will be conservative management with aggressive IV antibiotics, and if when the collections will resolve, then patient they can proceed to surgery. Otherwise, I can also discuss with the interventional colleague for the drainage, percutaneous drainage.
What
Uh,
is the first step? What is in your top of management for this case? See, overall,
or
we have three
drainage.
options in any. Yes. What?
Yes.
How could they drain this epithematous cholecystitis?
We can drain it percutaneously or
Okay. Yes, correct. So what will they do? Percutaneous
yes, we can
percutaneous
do it
drainage.
percutaneous drainage. Yes.
Yeah, what is the name of this percutaneous procedure? Percutaneous cholecystomy. Percutaneous cholecystomy. Again, percutaneous cholecystomy. Hello?
Cholecystectomy. Yes, percutaneous cholecystectomy. Cholecystotomy.
No, لا, cholecystomy, ostomy, not ectomy.
Okay.
Okay, why? Because this patient, sure, he is surgically unfit during this attack. He need more time for improvement. Okay, but first of all, they do percutaneous ultrasound guided cholecystomy. They put a catheter, drain, and later on, after improvement of the patient, because most of these patients are diabetic and generally unwell, so he
Yes.
unfit for anesthesia and surgery, everything. Okay. There
Okay.
are another complication here. Can you pick up this as a complication?
Air is seen in the region of the biliary tree.
Yes. What else? What
Over
about this
here.
air? No.
Air in the biliary tree. Yes.
Okay. What else? Is there are any clue for
Duodenum.
perforation? Perforation. Look. Is there are any clue of perforation? I think this loculi. Just leave them out.
Yes.
Leave. This one.
Because these have
Leave.
ill-defined walls.
Yes. Okay. You
Yes, these are
see it here.
locules in the region of
Okay.
porta hepatis.
Okay. So we have pneumopedia. We have possibility of perfusion. Thank you, doctor, so much. Next candidate.
Thank you.
Salam. 1 second. Request control, please.
Sorry, sir, I cannot. I am outside. You can.
Okay. 4-year-old male patient presented with abdominal distension and pain. Okay.
Sorry, sir. I think the candidate 13 is there. I am 14.
No problem.
So
Continue
if you want,
no problem. Continue and candidate 13.
apologies to candidate 13.
No problem.
Sir, I presented with the axial MRI T2 weighted images, in which I can see a large soft heterogeneous signal mass intensity that is seen anterior to the kidney and in the subhepatic region. It is
Yes.
extending to the suprarenal region as well. It is this is T2 and it is showing high signal with central areas of low signal, and it is
Yes.
relatively well defined. It is compressing upon it is pushing the gallbladder.
Doctor, your voice is
Multiple
interrupted.
flow voids are also seen, like
Hello?
low signal, dark signal voids are also seen within the mass,
Yes.
which might represent calcification.
Or
Sir, multiple signal voids are also seen
doctor,
within.
doctor.
Can you hear me, sir?
No.
Hello?
Repeat, please. Repeat, please. Your voice is interrupted.
Sir, multiple signal voids are also seen within the mass.
Yes.
Hello? Can you hear me,
Yes.
sir?
Yes. Hello?
Yes, sir.
Yeah. Continue.
Sir, sir, can you hear me now?
Some interruption.
Can you hear me? Yes, sir. Sir, a well-lobulated mass that is seen in the suprarenal region, in the suprarenal subhepatic location, and it has multiple flow voids are also seen within the mass, which might. Sir, actually, my internet might not be very good. That's why.
No problem.
Sir,
Go on.
can I have, sir, coronal images too? can I have coronal post contrast images or coronal views to localize the image and know the enhancement pattern?
See, this
Sir,
is post contrast. Post contrast.
It is showing avid post contrast enhancement with central low signal areas, non enhancing. Sir, in a
Yes.
4-year-old child with the mass in the suprarenal location, my first primary diagnosis will be a neuroblastoma.
What else? What else?
Sir, it can be, sir, it is showing enhancement along the peritoneum, extending to the anterior abdominal wall.
This is the mouse. It's the mass itself. See?
Yes, sir. Sir, it
This is the
can
mass.
be, sir, lesser possibility of the Wilms tumor because I'm not able to appreciate any claw sign and it is pushing the kidney backward.
See, where
Yes.
is this mass originate? From where? Look, where is the
Sir,
center?
suprarenal,
Okay, or
subhepatic.
hepatic. See the claw
Yes, sir,
sign of the
hepatic.
liver.
Yes,
See
yes,
the
sir.
liver,
Sir.
the claw.
Yes, sir.
So this is a
It's a,
hepatic.
it's a hepatic mass,
lesion,
sir.
enhancing, mainly
Yes, sir.
peripherally enhancing,
Yes,
with
sir. So
signal
primarily it
void.
can be a hepatoblastoma or
What?
mesenchymal hamartoma. Hepatoblastoma or mesenchymal hamartoma. These two will be the top differentials in this case.
What else?
I will.
Is hepatoblastoma contain this signal voids?
Sir, it can be, no, sir. Sir, it can be a giant hemangioma.
Excellent. See, is mainly show a peripheral enhancement and
Yes,
with
and center.
an enhancing center. Okay, thank you, doctor, so
Yes.
much. Really, you are brilliant. Thank you. My colleague, see, for coronal, there are a claw sign which indicates, see, the liver tissue is surrounding the mass. So the mass mainly centered on the liver. However, you have a right to order other sequences to rule out the being of suprarenal origin. See here, I think this is a suprarenal, this one. Okay, so it centered on the liver. And the doctor did very well performance when she mentioned about this signal voids. This very important criteria of a vascular or hemangioma or even AVM. Overall, this philipoli or calcification is highly indicated. This is a vascular pathology. Here, marked enhancement, mainly peripheral. Thank you, doctor. This is a hepatic hemangioma. This is not a hepatoblastoma. Hepatoblastoma is almost cystic, like the second case that I show you today. Okay? Hepatoblastoma, it was a hepatoblastoma. And the second case. But this case is hepatic hemangioma. Again, infantile hepatic hemangioma. Thank you, doctor, so much. Candidate 13.
Assalamu alaikum.
Salam.
I'm sorry, I'm on my phone. I cannot scroll.
Okay. 1-year-old male patient with jaundice.
Sorry, can we repeat this again?
1-year-old male patient presented with jaundice.
Okay, I have been presented with MIB projection for the MRCB, which is 3D for the MRCB for 1-year-old patient with history of jaundice. I can see that there is multiple cystic lesion noted within the liver parenchyma associated with dilatation of the intrahepatic biliary ducts within the right and left liver lobes. I can also see that there is dilatation of the common bile duct. In my routine practice, I want to see the rest of the sequence and images for better evaluation for this to detect the cause of jaundice in this patient.
Okay.
I want to start with the yeah.
Look here.
Yes. So I have been presented with coronal T2 sequence for this patient, I can see that there is increase in the size of the liver, which representing hepatomegaly. Here I cannot see any abnormal cystic lesion or hyperintensity 2 lesion within the liver, but I can see that there is dilatation of the intrahepatic biliary ducts, and also there is dilatation of the common bile duct. I want to see
What
if there
else?
is
What
if there
else?
is any pancreatic, if the pancreatic is duct dilated or not, and also I want to assess the pancreas to see if there is any pathology such as lesions or stones. Can we scroll this image? Yes,
Do you
here I
think?
can see.
Do you
Ah,
think? Do you think? Do you think in 1-year-old child we are searching for a stone? What is the
in
most?
some cases, yeah,
What is the
I
most common?
yeah.
What is the most common cause of biliary dilatation in neonates or very young child?
It could be due to biliary atresia.
Okay, but you should mention or you should search or exclude or prove signs with or without against biliary atresia.
Yes, yes.
What is the most important sign here that can be in favor of biliary atresia?
The most
Here,
important sign is
here in this MRI here.
in this MRI. Okay. I can see that there is absent of the gallbladder
Thank you,
because
doctor. Thank you.
I
This is
cannot
the
see
most
the
important.
gallbladder.
This is the most important. By the way, my colleagues, it may be hypoplastic gold. One advice for, one piece of advice to be grammatically correct. One piece of advice in my exam, they make us presented us with very tricky case in long reporting. Why? It was a neonate, and they gave us HIDA scan, and they gave us a confusing ultrasound. Really, many signs with again, favoring biliary atresia, and many signs against biliary atresia. What is this? But see, it was the most difficult and the most easier case. HIDA scan. You will not face HIDA scan in FRCR without biliary atresia. Okay? But finally, I asked myself, I only see HIDA scan when there are biliary atresia. So I report the case as biliary atresia. What is the confusing sign they give us? Number one, the common bile duct wasn't significantly dilated. Number two, the gallbladder was seen, despite it is of reduced size. But really, we are not expert about the pediatric, most of us. And then after I finish the exam, I go to Radiopedia, I read, I find many variant. One of this, if you find absent gallbladder or hypoplastic gallbladder. See, this is most important. It may be hypoplastic gallbladder. Okay, doctor?
Yes,
Hello?
yes. Thank you. Thank you very much.
Okay, see, this is CT, no problem. Look, my colleagues, there are very important sign, the cord sign, very important ultrasound, because in biliary atresia, it may be a case of hot seat, Viva, or a long reporting, or maybe short now. What happened? They will bring you first ultrasound, because this is the first line in any neonate with jaundice. Then you will find, see, this is the cord sign. For the cord sign. This, I think this one. I think this is the cord sign. Very thick, linear epigenicity here. This is called the cord sign. This is very important, very important. See a triangular cord sign. Triangular cord sign is a very important sign of biliary atresia. Where I will show this one. This one. Okay, my colleague. Okay. Cord sign is very important. Thank you, doctor, so much. It was a case of biliary atresia. What is your next step? Hide scan. Okay. Doctor, are you online?
Yes, I am. Thank you.
If we give hide scan,
Okay.
after how many hours should we wait?
24 hours.
At least 24 hours, because it may be some biliary stasis.
Yes.
And sometimes in hepatitis, there are delayed excretion, many factors. So tell the examiner more than 24 hours. I think in the exam, they give us 2 hours, 6 hours, 24, and 36 hours. And there were no any duodenal excretion. Thank you, doctor.
Thank you.
Yeah. We have any candidate now?
Yes, sir.
I hope you
115.
15. Thank you. Thank you that you are 15. Request control, please.
Candidate 5
Could
is
you
joining
scroll for
after
me?
this one, sir.
Really?
Could you scroll for me, sir?
Yes. Thank you, Dr. Anagam. Okay, doctor. 20-year-old male patient presented with high fever and right hypochondrial pain.
I have been presented with CT abdomen with contrast for 20 years old male with fever. The most striking abnormality is multiloculated peripheral enhancing area seen at the subhepatic region.
Yes.
With surrounding fat stranding.
Yes. One second. You have some noise from your side. Okay, no problem. Okay. What?
Okay, I couldn't appreciate the gallbladder separation. No, sorry.
Yes, don't worry about the gallbladder. This is the gallbladder.
Gallbladder looks fine, yeah.
Yeah. So what happened here?
Here, I think ascending colon looks thick wall.
Okay. But what else? What else?
I can see some
yes.
Peripherally enhancing central area. Yeah.
Could you follow it, please? Follow.
Yes.
Follow with me. Follow.
Yeah.
Follow. What is
it's
this?
Going down to the. This is likely appendix.
Excellent. So
this is appendicitis, subhepatic region, complicated with abscess formation.
Thank you, doctor, so much. Brilliant. Perforated subhepatic appendicitis. So complicated with subhepatic abscess. Okay, yeah. See, you did very well when you exclude the gallbladder. And then see here, this is the colon. Follow it, follow it, follow. This is the colon. This is a collection. See? This is the collection. And then the collection are going down. What is this? This is a tubular structure going down, just posterior to the ileocecal junction.
Cecal junction,
yeah. So this is a subhepatic appendicitis.
Abscess.
Thank you, doctor, for surgery and the drainage and every surgical management. Okay. Next candidate.
Thank you.
Yes, sir. Assalamu alaikum.
Salam. Request control.
Okay. I have requested.
I will help you to finish. Okay. Yeah, I will score for you. No problem. 85-year-old male patient presented with diarrhea, abdominal pain, and fever.
Okay. This is a CT scan chest, axial sections in the portal venous phase.
Chest? Are you sure
Sorry,
this chest?
abdomen. CT
Yes.
abdomen, axial section in the portal venous phase.
Yes.
In the liver, I can see that there is periportal edema.
Yes, what else? Are you sure all of this periportal edema?
Periportal edema as well as air in the biliary tree.
Again.
The
Look,
gallbladder
what
is
is
very
this?
distended.
What is this? What is this?
This is the common bile duct.
Okay, follow it here.
Okay.
Here.
Yes.
What is this? What is this?
This is biliary dilatation.
Okay. Biliary
And
dilatation.
gallbladder is distended.
Okay. Patient has fever. See? What happened?
Okay, I can see the calculi in the distal part of gallbladder.
So, what's your
So
diagnosis?
this is a case of choledocholythysis with intrahepatic biliary dilatation.
Okay. Again, what is the diagnosis again, please?
Choledocholythysis with dilated common bile duct and intrahepatic biliary dilatation.
Okay. Complicated by?
Cholangitis.
Okay. So it is a case of ascending
Cholangitis.
Okay. Ascending cholangitis. What's your next step?
I would this patient has very distended gallbladder, so I would refer my findings to the referring clinician. The patient might need cholecystostomy.
One second.
Yes.
When you tell the examiner something, be sure it will make a resonance in his mind. Patient has 2 gallbladder stones and has ascending cholangitis. And do you remember the examiner about the markedly distended gallbladder? So you must exclude something in the gallbladder. What must you exclude?
Any calculus in the neck of gallbladder?
Excellent. I think the neck is clear. Thank you.
Right.
Okay. What is your management?
This as the gallbladder is distended and it's very distended, the patient might need cholecystostomy before retrieving the.
No.
Okay.
Why? Look here, almost clear fluid.
Right.
The wall is not very thick. There are no surrounding hepatitis. So I think there are no cholecystitis. The cache is here. The problem is here in the biliary tract. Okay?
Yeah, so the patient will first need antibiotics followed by procedure to retrieve the stones from the common bile duct and relieve the obstruction.
Excellent.
ERCP
thank you,
and stone
doctor.
removal.
Thank you, doctor, so much.
Thank you so much.
Thank you for all of you. Tomorrow, my colleagues, we will meet as our regular time at 7 o'clock. Sarah's day, I am thinking about increasing the number of participation. I will announce with our coordinator, Dr. Nagam, at the group. But tomorrow at usual at 9:30 India time. Okay, 9:30. Thank you, my colleagues. Thank you for your attendance.
Thank you so much.